now request next speaker Ramesh Venkatesh to speak to us on surgical related acronyms in imaging.
At the outset, thanks Divyansh for this opportunity. And let's start very fast. Okay, I've been asked to talk about 4 acronyms. So I'll start with the first one, which is basically related to the macular holes and the macular hole surgeries. So the first one is going to be on the lamellar hole LHEP, which we commonly call them macular hole factors, the SANFL and the DONFL. So LHEP is basically the lamellar hole epithelial proliferation. So it's basically, you can see with the arrow that there is a homogeneous mass of medium reflectivity which is lying over the retinal surface. So in a patient with lamellar macular hole, you have a mass-like tissue which is present at the edge of the lamellar hole, which is homogeneous and medium reflectivity. And what causes the LHP is basically, there have been multiple theories which have been put forth. One of them being the migration of the retinal molar cells to the epiretinal surface, and in some cases there is migration of the retinal pigment epithelial cells as well. And with this photograph, you can see that there is an LHEP, but what you can also see in the central part is there is a discontinuity of the ellipsoid zone or the ISOS junction. So LHEP basically is associated with poor baseline visual acuities. They have larger macular hole diameters, they have a very thin residual retinal tissue, and there is a higher rate of inner segment outer segment band disruption. What is the clinical relevance? Now, patients without LHEP, they usually tend to present with a good visual acuity, and therefore they do not have any disruption of the outer retinal layers, and therefore because these patients have a very good baseline visual acuity, most of the retinal surgeons or the patients who present with lamellar macular holes, the retinal surgeons tend to avoid or defer surgery in these cases. However, in LHEP cases, there is usually an outer retinal layer disruption, and there is a reduced visual acuity, and therefore the visual acuity outcomes even after the surgery, they tend to be not very good. So LHEP or the epithelial proliferation is not only seen only in lamellar macular holes. So the term LHEP, the lamellar macular holes, is not the right way to describe it. It can happen even in cases with full thickness macular holes. With this photograph, you can very clearly see the epithelial proliferation happening at the edge of the full thickness macular hole. Even in this photograph, you can see that there is this, and therefore the term LHEP is now being changed to what is called as the EMPF, or what is known as the epimacular proliferation, which you see. And there is a surgical relevance to cases where you have LHEP or epimacular proliferation. The peeling of the proliferative tissue is important because it can lead to recurrences of ERM formation if not removed completely. And aggressive peeling in a case of epimacular proliferation in a lamellar macular hole may lead to a conversion from an LMH to a full thickness macular hole, and care should be taken not to forcefully pull it, and applying a minimal traction may theoretically reduce the possibility of the retinal tissue or the formation of a full thickness macular hole. So this is our publication where we spoke about the epimacular proliferations in patients with lamellar macular holes, and this is something which we can have a read later on. Now let's look at the macular hole factors. We know the 4 important factors which are important in preoperative decision making is the hole forming factor, the hole index, the macular hole index, the diameter hole index, and the tractional hole index. I'm not going to stick to these indexes, but I'm going to talk about something which is beyond it. So this is what is called as the MAI, is known as the macular hole area index. The MTAI is called as the tissue area index. The CSAI is called as the cystoid space area index, and this is something which we calculated using the IMAGE algorithm, where we had the full thickness macular hole, from which then we create a trapezoid area. That is the area which is going to be considered as the total area of the involving the on the OCT. So the C is the entire thing, and then the C, you can see that there is a dotted line which is shown, which is actually calculating the area within the macular hole itself. Then you subtract that area, what you're left, you do a binarization, then you have the cystoid spaces and the tissue spaces. The tissue spaces are being shown as hyper or white in color, whereas the cystoid spaces are black in color, and that is how you calculate the cystoid space area and the tissue area index as well. How is it important? Because large macular hole area, when you have a very, very large macular hole, they are associated with failed macular hole closures. And when we say type 2, basically we indicate that they are not the typical macular hole closures which we expect. And you can see that the area under the curve for the macular hole area index is much, much high. So this is again our publication where we spoke about these indices which help in predicting the macular hole closures for idiopathic macular hole. Let's look at the next entity, which is the SAN-FL. The SAN-FL is basically a swelling of the arcuate nerve fiber layers, and what it tells you that it is occurring after the internal limiting membrane peeling in an acute immediate postoperative state. So let me show you a photograph of a full thickness macular hole preoperatively, and this is after 8 days post the macular hole surgery, where you can see these radiating lines coming from the edge of the disc. And what you can see on the OCT, when you pass an OCT scan through that area, you can see there is a focal thickening of the nerve fiber layer. So this SAN-FL, it actually regresses or resolves over a period of time. These are multicolor images of the same patient, where you can see these radiating lines which are happening immediately post operatively, and over a period of time they start resolving itself. These are the OCT photographs, which you can see that the SAN-FL keeps decreasing over a period of time. So it happens in the immediate post-operative period. It is the swelling of the nerve fiber layer when along the arcuate nerve fibers. It is a transient phenomena. It resolves spontaneously and does not affect the visual acuity. Let's go to the last entity, which is the DON-FL. It was initially called as the dissociated optic nerve fiber layer, and it was Spade who actually clarified this and said that there is nothing affecting the optic nerve. It has nothing to do with the optic nerve fiber layers, but it is just the inner retinal dimplings which you get. And these patients, so this is a case which I wanted, this is the OCT of the previous case itself, where you can see these inner retinal dimplings which are seen on the OCT scan. And this morphological evaluation, this paper, it actually says that this can happen over a period of time after the macular hole surgery, not something like the SAN-FL where it happens immediately, but it can happen over a period of time, over the first 12 months following the ILM peeling. Let me show you these photographs of my cases, where you have, this is the preoperative photograph. Following the closure, following the surgery, you can see the SAN-FL developing, but the macular hole unfortunately did not close. Then we redid the surgery, where we gave further gas injection and prone position, and now you can see the SAN-FL is totally reducing. But what you can see at the end, this is almost a year later, you can see these multiple spots which are seen in the, or depressions which are seen on the fundus examination. This is much well seen on the blue reflectance and the green reflectance imaging, where you can see these hyporeflectant spaces which are seen. And when you do the OCT or the on-fast OCT in these spaces, you can see these depressions or defects which are seen, which are suggestive of the inner retinal dimplings, which are also seen on the OCT B scan along with it. So DON-FL occurs in the area of ILM peeling. They are inner retinal dimples. It's a misnomer and nothing to do with the dissociation of the optic nerve fiber. It is not seen in the immediate post-operative period and does not have any effect on the visual acuity. So to summarize, LHEP is same as epimacular proliferations, and they indicate poor prognosis. Macular area index, it indicates a poor closure. Larger macular area index indicates poor closure. SAN-FL, it's seen in the immediate postoperative period, and it's a transient swelling of the arcuate nerve fiber layer, while DON-FL is not seen immediately, and they are inner retinal dimples. Thank you so much.
Thank you very much, Ramesh. Beautiful photographs, and it's nice to know that what we do doesn't affect the visual acuity, though probably later when we do secondary visual functions, we'll feel different. Just want one quick question while Pradeep is getting his case ready. Anyone from the audience? Otherwise, I'll ask him one. What does LHEP or epimacular proliferation look like when you're operating? How do you identify it clinically?
So
because there are many times we think that's what we are seeing.
So it looks like a dull yellowish orangish tissue which is seen at the edge of the macular hole, ma'am, actually, and it's a very tough tissue. So when you're trying to peel up the ILM, it at the edge of the macular hole, there is a tissue which doesn't actually come as easily as when you try to peel the ILM tissue. So it looks like a homogeneous yellowish, dull yellowish tissue which is present.
Yeah, and doesn't stain well also.
Doesn't stain well.
It doesn't stain well. You have that little rim which doesn't stain.
It's basically on the epiretinal membrane. It's on the epiretinal surface. So that's
yeah. Thank